Hello, everyone. On behalf of Ortho NorCal, we'd like to thank you for joining us this afternoon. Today, we will be discussing low back pain's missing piece, diagnosing the sacroiliac joint. My name is Nicole Gossett, and I wanted to take this opportunity to thank Dr. Jeffrey Coe and Dr. Tina Malumphy for their work and interest in considering the SI joint as a cause of chronic low back pain. Now, I would like to introduce our panel speakers, Dr. Jeffrey Coe, orthopedic spine surgeon, and Dr. Tina Malumphy, spine intervention, electrodiagnostic medicine, both from Ortho NorCal, located in Los Gatos. Dr. Coe's interest in innovative spine technologies and his background in engineering provide him the ability to understand underlying biomechanical processes and problem solving to provide the best solutions for his patients with injuries, deformities, and other diseases of the spine. Dr. Coe teaches other spine surgeons new techniques to further advance state-of-the-art spine surgery. Dr. Malumphy is a physiatrist who specializes in spinal pain management. She has been an active member of the Spine Intervention Society for the last 20 years. She enjoys treating patients with minimally invasive procedures to help them avoid surgery and/or help surgeons identify the source of the pain. Before I turn the presentation over to our distinguished panel, I would like to solicit some input from the audience. We're going to launch a poll to get a better sense of how long each of you have been experiencing low back pain. So this first poll question is, how long have you experienced low back pain? And if you could click on or select one option. We'll give it just a minute to allow you to answer. Okay, so seems to be tapering off. Let's look at the answers that we have.
Wow, that's pretty interesting, Dr. Coe. Most of you have tried oral medications. That's very typical, over the counter for sure. Physical therapy also is very high at 91%. 56% of you have done chiropractic care, and about a third of you have previously tried injection.
All right, so I think that we may have embedded our third poll question right here as a follow-up, Dr. Malumphy. So we talked about, you brought up an interesting point about which kind of injections. So for those of you who have tried injections, we're curious about what type you have tried, and please select all that apply for you. There's non-image guided or trigger point SI joint injections, ultrasound or image guided SI joint injections, facet injections, medial branch block, or an epidural injection. So once again, check all that apply, and we'll give you just another minute to let you make your selections. Okay, great. It looks like they're tapering off. So let's look at these answers.
Interesting. Non-image guided injections is about 20%. The actual SI joint image guided, meaning ultrasound or fluoroscopy, 70% of you have tried that, which is great. Facet injections about 40%. Medial branch block injections 10%, and epidurals 30%. Thank you, Nicole.
Very good. Absolutely. Take it away. Thanks.
So let's talk about the SI joint and how we diagnose that in some of the non-surgical managements that I can offer for you. Today we're going to go over how to diagnose the SI joint dysfunction, some of the provocative testing that I can do, and the injections that I do. Diagnosing the SI joint is rather straightforward. The patients most of the time will come in, and if you ask them to put one finger on where they hurt the most, very commonly they will put it right over that dimple Dr. Coe was mentioning that's just kind of above your butt cheek and below the L5 vertebral body. So if you look at the stats of it, it's below the L5, like I said before. you got to consider the SI joint. But if they're having pain that's above the L5 vertebral body, then it's more likely related to their vertebral disc problem or joint problem. The other things we can do is an anesthetic injection. That's done under the fluoroscopy. If patients get greater than 50% relief, then we consider that as a probable source of pain. I often like to do that on an injection a second time to make sure that we're not getting a placebo response. If the patient doesn't respond at least 50% improvement, then you're looking at other sources of the patient's anatomy as part of their pain. Here are some provocative tests that we do in clinic to see if a patient has SI joint pain. We can have the patient lying on their back, and the practitioner will cross their arms and press on their pelvis, not looking for pain in the front of the pelvis, but rather referring pain into the back. Another exam maneuver is called the thigh thrust, where the patient once again is lying on their back. The practitioner stabilizes their pelvis, and we move that thigh up towards their head, causing some force onto the pelvis. Another one is called the Faber's maneuver, or the figure of 4. This one, once again, you're lying on the back. You externally rotate your hip, and your ankle is across your knee. Another one I commonly do in clinic is when the patient is side lying, I push down on their pelvis to see if it causes direct pain. The last one is called the Ginsland sign, where the patient once again is lying supine. They pull their knee towards them, and the practitioner pushes down on the opposite thigh. If you have 3 out of these 5 tests that are positive, it is highly likely that your pain is coming from the SI joint. So this is how I undergo or do my procedures for an SI joint injection. Patient comes in, they lay down on the procedure table. I use my imaging to diagnose or see where that SI joint is. I use a very, very tiny skinny needle about the size of a flu shot needle. I numb the skin, and then I walk that needle into the joint under the guidance of my imaging. I've got a very, very small amount of contrast in there to make sure that it's going into the joint and not in the vasculature or out of the joint. And then I put in some anesthetic and sometimes some steroids, depending on what we're trying to tease out or treat. Other non-surgical treatments. Well, there's obviously anti-inflammatories, pain medications. Chiropractic treatment can be very helpful for this type of pain as well. Physical therapy for certain, strengthening that core, reviewing your proper body mechanics is very important. SI joint belt. We're going to show you a picture here in a minute with that. A lot of pregnant women find that very helpful. There's the steroid injections, and then there's what's called radio frequency ablation, which is treatment to the nerves. I'll show you what that means shortly. So here's an image of the SI joint, the belt that wraps around your waist. It provides a solid support of those iliac bones and that SI joint. A lot of people find it very helpful, but there's often some that just don't find it very comfortable and stop using it. Physical therapy, once again, is very important for body mechanics, helping you go through your activities of daily living, using proper body mechanics. They can also do some soft tissue mobilization over that joint. Here is an image of the diagnostic injection, once again, performed under fluoroscopy, small amount of contrast dye, and a small amount of anesthetic and possibly steroids. Radiofrequency ablation. This is another potential minimally invasive procedure to help with SI joint dysfunction. As you can see by all the red branches stemming out from those circular holes going out to the joint, there's a vast amount of nerves that supply the SI joint, and those nerves can be ablated or heated and basically die back. It's called Wallerian degeneration. It takes on average about 11 months or so for those nerve roots to regrow. So it's not a permanent solution. It is definitely an option for treatment, but it does not stabilize that joint if that's the primarily dysfunction. Once again, I'm going to hand this over to Dr. Coe.
Okay, thank you, Dr. Mullins. Excellent presentation. So I'm going to talk a little bit about minimally invasive surgery. Our co-sponsor, SI Bone, has developed a system that I've been using for over 10 years now that involves a minimally invasive method of stabilizing the SI joint. Historically, I've done SI joint fusions, but it's been relatively rare because it's kind of a brutal operation, which means either going into the front of the pelvis or opening up the back of the pelvis and getting large amounts of bone graft and putting in rods and screws and plates and things like that. But the reality is it works very, very well. And it's very, very innovative. A doctor who was actually a foot and ankle surgeon in conjunction with an orthopedic surgeon in May, Dr. Mark Riley, the orthopedic surgeons in Maine that first did this procedure, he developed this triangular shaped implant. I don't know if you can see it, this little triangular shaped implant here that is put over a wire and usually use 3 of them to help stabilize this, the SI joint. It's done through a minimally invasive incision, and bone graft goes through and around it to stabilize the joint and ultimately result in a solid fusion. The procedure length is right in an hour, plus or minus 5 to 10 minutes. It actually takes longer to position the patient and get all the x-ray machine in and everything else than it is to actually do the procedure. But it's a very, very successful procedure. Here's a video. Let's see if I can get this thing to run. That shows kind of how it works. You see the SI joint, and you can see there's this painful micro motion there. There's a lot of stress on that joint, and those implants go in over the wires. You can see how it looks, and it's a little tiny incision over either the left or the right side of the buttock region, if that's necessary. Here's a model here that shows the implants in place. Pull it back yet. Okay, there you go. Okay, you can see the side view of that. All right, this is a plastic model of the pelvis, and the hole in the implant. If you can see the hole in the implant, that's where we would put this over the wire. So it's very similar to fixing a hip fracture, except in this case we're treating the problem. So what about the results of the surgery? After multiple publications and now over 50,000 procedures using this technique and 10 plus years of collective experience, 9.5 in my case, 75 publications of very high patient satisfaction of 91% with this surgery. And a randomized controlled trial overview, prospective multicenter randomized controlled trial, iFuse with non-surgical management. 148 segments or subjects, patients were enrolled and treated. It was a 2-to-1 randomization. So 2 patients will immediately get the iFuse and 1 would get further non-surgical management. Now, how do you get patients to enroll for a study like that? Well, you tell them, well, if you're in the non-surgical management, you're not doing well, after a certain period of time, we will let you have the surgery. All right, 19 clinical sites. We were one of the sites for a secondary study that looked at just clinical results. But this study showed follow-up at 6, 12, 18, and 24 months, level 1 evidence, the highest there is, and showed the benefit. Now look at the left side of the slide, the blue line versus the green line on the left part of the slide, non-surgical management compared to the iFuse treatment. And at 6 months is when, okay, you're not doing so well, you can cross over and have the surgery. And you see the purple dotted line, those patients that at 6 months went on to surgery did just as well and stayed just as well as those that had the surgery. And those that didn't cross over were kind of doing okay. So it's really the worst of the non-surgical group that had the surgery. And those kind of did okay with non-surgical management. And you can look at the disability index, which really tells the story. The disability index on the right slide shows a different kind of measure, not pain, but the disability. And you can see the real driving thing for having the surgery was how disabled they were by their SI joint pain, not how much pain they were having necessarily. So that really kind of nailed it. I mean, it shows that the SI joint is a source of pain. If you fuse a joint that doesn't even have that much motion to begin with, it only has 1 to 4 degrees of motion. It's motion that's really only missed in a high performance athlete, such as a pitcher or quarterback, that the SI joint rotation is used for part of this. So it's really a good operation with a low complication rate and a very high success rate. And the results are sustained. You can look at 54-point improvement in SI joint pain on a 100-point pain scale. That's 54. And to have clinically meaningful improvement is 20 points. So that's more than twice as much that would be considered minimally meaningful improvement. And the same is also true for disability, where you have 15 points to have clinically meaningful improvement in the disability scores. And it's really almost twice that with mean 26-point improvement. So here's the necessary slide, since we're being co-sponsored by the SI Bone Company, that shows about the FDA disclaimer. So anytime that we have a co-sponsorship by a corporation, we have an FDA requirement to show that. And I won't read it. I'll let the slide sit there for a second or two so you can look at that. And we'll move on. And then you can look at the sibone.com/risks if you have more information about that, or talk to me or Dr. Malumfi or whoever your doctor is that you want to talk about that for the risks. So in summary, if you have low back pain, ask your physician if she or he has considered the SI joint as a possible cause of the low back pain. If you have back pain that lateralizes to the left or to the right and it's not midline pain, there's a really, really good chance the SI joint is part of that, maybe as much as 1/3 or even more if it's lateralized pain. If the SI joint is a source of the pain, there are numerous non-surgical treatment options that Dr. Malumfi outlined. If non-surgical treatment is successful, minimally invasive surgery with the iFuse implant system may be an option for some causes of SI joint pain. So here are the references. I don't expect you to read them. There won't be a quiz at the end, but they're there available, and Nicole or any of the representatives, or you can get these references from the SI or SI Bone website if you're interested in looking at the source literature. Thank you very much.
Absolutely. Thank you so much, Dr. Coe and Dr. Malumfi, for that informative presentation. It's always interesting to hear both perspectives since you work so closely together on the diagnosis and treatment of SI joint patients.